On behalf of INEDSYS, I would like to welcome you from New York. Today we have Professor David Kleiner. Dr. Kleiner doesn't need an introduction. He's well-known and world-renowned hepatopathologist. He's a graduate of the University of Chicago, Pritzker School of Medicine, and earned a Ph.D. in chemistry from the same institution. After completing his residency in Anatomic Pathology at the National Cancer Institute, he joined the faculty of the Laboratory of Pathology at the NCI, currently serving as a senior research physician and chief of the Postmortem Section. Dr. Kleiner is a leading expert in hepatic pathology. His research focuses on chronic liver diseases, particularly in evaluating histological responses to therapy. While based at NCI, he collaborates extensively with NIDDK-sponsored networks, serving as co-chair of the pathology committee for the NAS Clinical Research Network and as central pathologist for the Drug-Induced Liver Disease Network. Dr. Kleiner is also involved in the liver cancer Moonshot project and has contributed to the hepatocellular carcinoma and cholangiocarcinoma arms of the TCGA and CPTAC initiatives. He has authored over 400 scientific articles, multiple book chapters in the liver pathology. With that introduction, I will hand it over to Dr. Kleiner.
So yes, thank you again. This is going to be a little bit of a tour of the development of digital pathology over the years. And hopefully you'll come away with this with some understanding of what this looks like from the pathologist's point of view. I imagine most of my audience here are hepatologists or people who are familiar with the liver pathology. You've seen biopsies, but as a laboratorian, we have other interests and concerns when it comes to the applications of technology, because our goal is to make things as seamless and transparent for you, without you having to worry about all the stuff that I have to worry about. So I do have some uncompensated collaborative projects with a couple of companies, including HistoIndex and PharmNest, which are digital pathology AI companies, and High Tide, which is a pharmaceutical company. So what I'd like to do this morning, or this afternoon, or this evening, depending on where you are, is review the development of image analysis and machine learning, because I think knowing that background will help you see all of the challenges that we've had along the way. And these challenges still are there. They need to be overcome with each new technology. I'm going to briefly showcase some of the AI applications in tumor pathology, but most of the focus here will be on non-neoplastic liver disease and the assessment of chronic liver disease. And so what I want you to get out of this is that there is both promise and peril to these techniques and using them clinically, as there is with any AI application. We had a really excellent symposium yesterday at the NIH on artificial intelligence applications, and the keynote speakers spoke of the same kinds of things, both the promise of AI and the perils. And I think these are real, and we have to be upfront about them and understand the limitations of the technology that we're applying, and not assume that the answers that it gives us are always correct. I am making a couple of assumptions in this talk, one of which is that you're at least familiar with the scoring systems that are used for chronic liver disease, and in particular for steatohepatitis. There's going to be a little bit of that in here, but I'm not going to go over the scoring system or what we do to assign the scores. So we're going to start with morphometry. Morphometry is probably the oldest type of image analysis we have in pathology, and it's very simply the quantitative measurement of the form especially of living systems or their parts. And and pathologists have been doing morphometry since we started looking at slides. And the most basic form of morphometry is enumeration. So you want to know how many things are there. And so on the left here, you can see a liver biopsy, actually probably a tumor biopsy that has mitotic figures in it. And so one of the things that pathologists do pretty routinely is we count mitotic figures. This is a terribly tedious process. And believe me, if there were some image analysis program that would work pretty well for this, we would be using that. But it actually turns out that this is quite a difficult problem for computers to recognize these small dark objects with accuracy. So there aren't really good tools out there for counting mitotic figures. The other thing you can do is you can count other kinds of objects. Like here we have CD8 T cells that are stained with an immunostain. And now it would be very easy for a computer to count these. It could identify nuclei and then look for nuclei that are surrounded by a little brown stain, and it could count those things. It'll ignore little bits of brown like this because they don't have nuclei in them. So you could train your system to count these cells in this fashion. So one of the other questions we're often asked is how much area is occupied by the objects. And I'm going to show you this little amusing example using this relatively famous painting, how much of this painting is darkly colored. And this is a question that is directly related to some of the things I'm going to show you. The earliest measures of fibrosis were how much area the collagen takes up in the biopsy, how much steatosis, how much the steatosis vacuoles occupy. So this is an important question. So you might take this painting and then threshold it to make it black and white, right? So grayscale. So now you've taken your three-dimensional color scheme, or four-dimensional, depending on which color scheme you were using, and you've made it one-dimensional. So every pixel has a value, and we can know what those values are. And then what you might do is you want to decide which are the dark pixels and which are the light pixels. So you threshold it. So you draw a line through the histogram of pixel density, and you pick out the pixels that are more dark than they are light, and then you count them up as a total of the area. And in this particular painting, this turns out to be 37.52%. And so you can see that you've taken this beautiful painting here and you've turned it into a number, 37.5. And that may be what you need. You need to know the fibrosis stage, or you need to know the percentage of fat in a biopsy. But recognize that you're throwing away a lot of information when you do that. So other kinds of statistical measures can also be used to characterize the population of objects. So this is an image of a second harmonic generation scan of liver biopsy that's probably close to cirrhosis, if not cirrhotic. And I'll show you this technology in a little bit. But you can analyze this in a whole different way, a lot of different ways. So you can look at the fractal dimension, which gets at architecture. You can segment it. You can identify where are the portal areas, where are the sinusoidal spaces, where are the septa, and you can separately evaluate each one of those areas. If your resolution is good enough, you might be able to look at individual fiber size and their orientation and their relationships to one another. And there are at least two systems out there that use this methodology in their analysis. And then you can look at ratios of objects or measures of proximity. So you can measure how close things are now, or you can measure the size of these nodules. you know, as a proportion of the biopsy width or other thing. So there's lots of things that you can do once you can measure stuff. All right, so we need some definitions, excuse me, to start with. So digital pathology it's a very broad term. It's the use of digital histological images by humans or machines for diagnostic or analytic purposes. And so it's as simple as, you know, scanning a slide and sending it to your colleague in some other country or some other state and saying, what do you think, right? So you're showing them a digital picture of the biopsy for a diagnostic purpose, or you can then take that and use it for analysis. So then image analysis takes that into that machine analytic part. And so it's a computational evaluation of images based on simple assessments. It doesn't always require AI methods. And so for straight up image analysis, I like to keep this separate from the neural network type AI applications. And there's still a lot you can do with just computational evaluation of images. You don't need to go into more complicated methods. And then there's machine learning. So machine learning is a field of artificial intelligence that uses algorithms to teach computers, you know, what you are seeing, right? So they can learn and improve from the data without necessarily you programming them to recognize certain things. So, and that can be supervised or unsupervised. And so the machine learns in supervised learning. The machine learns from images that pathologists annotate. So I circle the balloon cells, or I point out the steatotic vacuoles, and then the machine figures out how to recognize those things based on the data in the image. And then there's unsupervised learning. And to be quite honest, what I'm going to show you is not completely unsupervised, because it is learning from the images and matching them to outcome data. So you might show it a whole series of biopsies and say, you know, these patients died within 4 years, or they came to some outcome, some hard outcome in 4 years, and these cases did not, and find me the differences. And probably what the machine would do, it would focus on the fibrosis, because that we know is the most significant thing, but it might find other stuff too. That's not completely unsupervised. Totally unsupervised learning, I learned yesterday, is where you just hand the machine the pictures and you see what it does with it. And it starts to make associations. It'll group things on its own. It can categorize stuff. So you can get away from even this sort of limited unsupervised learning and then get something out of the image. So there are lots of applications of AI in pathology. So you can start with this image here in the middle. This happens to be a tumor, and I'm sorry, I don't know what kind of tumor, but you can do this with most tumors. You can subtype them, you can grade them just by pattern recognition or looking at the nuclei. You can segment, detect where the tumor is as opposed to the normal tissue, and you can segment those areas and detect the tumor areas. You can use this in that unsupervised learning to predict outcome or a treatment response. And we're learning now that we can actually make molecular profile predictions. So you can look at a tumor and you can say, you know, what transcriptomic pathways are elevated in this tumor. And that can help you find molecular targets, even without doing the molecular analysis. So there's a lot of information in an H&E. All right, so now we're going to go through non-neoplastic disease. Actually, I need to keep an eye on the time here so I don't run over. So in the beginning, so the early evaluations were just simple applications of image analysis, right? So we're just teaching the computer how to recognize objects, mostly by programming or by thresholding, those very basic things. And this is going to be a problem this whole way through. I'm sorry, my my IT. The IT control over my computer is out of my control. And a lot of these were based on color differentiation or shape. So with steatosis, you're looking at optically clear round objects. And so you can say, okay, I'm looking for clear things, and they have to be a certain shape, a certain amount of roundness. And the computer will then separate those things from, say, sinusoids, or if you've got some sort of size discrimination, it can separate it out from vessels. And then fibrosis is a simple color differentiation. So you can use a Masson stain or a serious red stain and then threshold on the color. And the images were actually first obtained with digital cameras. So you take multiple pictures of the biopsy or whatever, and then later on we had these amazing whole slide image scanners, and we could use those. Sometimes you need manual intervention. So nowadays, I think we've taught the computers to recognize what areas to exclude, but early on we had to exclude these things by hand. So this was one of the earliest papers, it may be the earliest paper in this area of liver disease to use digital computational morphometry. So this was a steatosis evaluation. And so what they did was they took pictures of the biopsy, and then they identified the vacuoles by how round they were and size. And so all of those things could be done computationally. And then they added up the area, right? So the percentage area. And they in this particular study, they plotted that morphometric quantitation against an early form of PDFF, fat fraction MRI, and showed that there was pretty decent correlation between these two methodologies. So there are a lot of questions about, how this happened, and, the pictures, unfortunately, were not very good resolution, but there is a limitation to how easily you can recognize these lipid droplets. Once they're down too small, the computer no longer sees them because they're too small. But that's not going to make much difference in the total area. So you could probably ignore that, but it's important to know that you're missing it. So this was a little bit, so that was in 1996. And so now more than a decade has passed, and we're still using digital cameras mostly. And this was a study my colleague Zach Goodman did with one of the clinical trials that he participated. It was a Hep C trial. And he used serious red stains, which have a lot of advantages actually when doing morphometry of liver biopsies for fibrosis. And so you could take the serious red stain, you can see the background stain is very even and pale yellow, and the collagen is nice red. It's a very simple stain to do. It's very reliable. The color is actually proportional to the thickness of the section. So you can actually measure the thickness of the section in fibrotic areas by the absorption or the intensity of the red. And then so you can then threshold it, and then you can do pixel counting to get you to a collagen proportionate area. So this was one of the first papers to do that. And one of the things he pointed out was that what you started with made a big difference. So if you had a terribly fragmented biopsy here, it could miss the fact that it's cirrhotic. I mean, to me, this is clearly cirrhotic. You have fibrosis around the edges of these little pieces. But look at these pieces here. It would be very difficult for the computer to come up with a very high collagen proportionate area. And so you need adequate biopsies for evaluation. So one of the things that he showed was that the collagen proportionate area was associated with the Ishak stage. So that's an expected outcome. So we're all glad that happened. But the other thing that he showed, this was a negative study, and he could show that there was a shift in the amount of collagen. So the light gray bars here is the histogram of the biopsy collagen at the beginning of the study, and this was the shift towards the end, and you can see that the median or modal density shifts from about 0.06, 0.08 up to 0.14, 0.16. So there's quite an increase in collagen. The stage may not have changed. It may have stayed cirrhotic, but now you've got a lot more collagen. So this was a little bit farther along now, 2013. Now we're using whole slide imaging. Aperia was one of the first companies out with a nice whole slide imager that was easy to use. And this was also a Hep C study. And what they wanted to do was they wanted to look at these two stains, serous red and trichrome, and evaluate them separately. And so one of the things that you could see from this is that when you have two biopsies that are each stained with these stains, the trichrome stain comes out with a lower collagen proportionate area than the serous red. So the serous red's picking up more of the collagen. And they found it quite difficult actually to threshold properly on the trichrome. And to be honest, looking at their pictures, I think the reason was that their trichromes are not very good. And trichrome is a difficult stain to do well. So if you have a choice and you're doing this kind of analysis, a serous red stain is a good choice. It's probably better than the trichrome. So here's actually two biopsies I stained side by side. This is consecutive cuts. So the collagen isn't exactly the same distribution. It's close. But what you can see in the serous red stain is that you're picking up a lot more of the sinusoidal collagen, which is probably mostly normal collagen. And that's one of the reasons why this is so picks up so much more collagen than the trichrome. But also you get a lot more definition of the fibrils. So you can see much more fibrillar character here, and a computer image analysis can take advantage of that much better than it can take advantage of the trichrome. And so this was their final result, to just show that across the stages, trichrome, which is in these hatched boxes, had much less collagen proportionate area than the serous red. So they're not interchangeable. You have to pick one or the other. So this was one of the first studies I was involved in. And this actually did use artificial intelligence and machine learning. So what we did was we annotated these different white spaces, steatosis and all the veins and the ducts and the artery. We annotated these areas, and then the computer with a neural network figured out how to tell the difference between all of these structures. And so here's kind of the workflow here. You take the original image, it gets thresholded in a couple of different ways with the green channel and with a straight grayscale, and this gives you the sort of the foreground background image of the whole biopsy. So that's your biopsy area, and then you identify the white regions, and then you pick out the white regions that are classified as steatosis. And this is an important table to look at. This is a confusion matrix. A confusion matrix is where you know what the ground truth is. So we went back and we looked at the biopsies and the assignments that the computer made, and we said, is this right or is this wrong? And if it was wrong, we said what it was. So if the computer looked at a bile duct and thought it was steatosis, or vice versa, then we would flag that. And so down the diagonal here are the correct assignments. So you can see it was actually pretty good at some things. So steatosis, it was actually really good at picking out macrosteatosis. But sinusoids, it often mistook for other things. And so that was the major confusion. Sinusoids can look like a lot of different things. They can have round shape. They can be irregular and be mistaken for other kinds of structures. So if you're trying to actually classify all of these different regions using your neural network, that's going to be one of the challenges that you face. And again, so it's important to know that, well, the computer isn't perfect. I mean, these are pretty simple determinations for pathologists. We're not going to mistake a bile duct for a fat vacuole, but the computer doesn't always know that, and so it's important to know what proportion of the time the computer fails, and to understand why it's failing, and that helps you improve the model. So we did do this, and actually, because the steatosis was pretty good, we could just go forward with this model and not worry about the misassignment of other structures. And the percent of steatosis compared to where there were two pathologists, me and one other person, the percent of steatosis, mapped to grade in the same way that you see it in others. And we actually used sort of half grades when we classified something differently. We picked the median, and you can see that actually maps properly along everything else. So this was another study of steatosis that I did actually with Dr. Satapathy and his team. And so again, I was the pathologist grading the steatosis. This was a bit of a different kind of approach, but again, extracting the round objects, recognizing the round objects, making morphologic determinations based on computational criteria, and then you could see how the computer identification of fat vacuoles matched up with the original H&E. And this was not we didn't do a cycle of training here. The assignment that we got out at the end was pretty good, and then we could use it for analysis. But what was interesting about this paper and this study was that we didn't look just at area. So that's the typical thing that you measure with fat, is how much area of fat vacuoles is, how much of the biopsy is actually lipid. And so that's the fat fraction. But we also looked at the ratio of vacuoles to hepatocytes. So this is the percentage of hepatocytes that have a vacuole in them. We looked at the radius of the vacuole, how circular they were, how the regional isotropy, or how irregular the distribution was, and then also the nearest neighbor distance, which you can see up here. So if the fat is distributed widely, then the nearest neighbor distance goes up, and if it's packed together, then it goes down. And one of the interesting things for me was that when you compared the fat fraction or the vacuole to hepatocyte ratio in these images to what I scored it, we got a much better linear result with the percentage of hepatocytes, which is actually what I said we were doing way back in 2005 when we set up this semi-quantitative score. Everything, all of the other, MRI, PDFF looks at fat fraction, but the pathologist is actually probably more looking at this. And so that's one of the reasons why these two things can be a little bit different. So this was also a photograph based analysis. It wasn't whole slide images, but what that allowed us to do was to look at regional variation across the biopsy. So you can see how the fat fraction varied, how the radius of the vacuoles in each photo varied, the circularity, the nearest neighbor distance. So in the middle here, the nearest neighbor distance kind of spreads out because you're looking at, a lower population of fat vacuoles. And so there might be information in this kind of analysis that might actually be more relevant than the total percentage of lipid in the biopsy. Another study that I did with the same University of Indiana group was to classify lobular inflammation and ballooning. And I'll tell you up front, this was not as successful. These are the hardest things for computers to accurately recognize. And there we go with the Windows 11 upgrade. I'm so sorry about this. Had I known that it was going to do this, I would have just done the upgrade before. So there are two measurements that are important here. One is precision, which you can think of as the positive predictive value of the assignment, and then the recall, which is basically the sensitivity. But these are the terms that are used a lot in image analysis. So we again went through, the pathologist circled the balloon cells or the foci of inflammation, and then you can see the computer divided up the biopsy into tiles and then assigned probability to the tiles, and based on the probability thresholded that and came up with a result that either really matched really well where the balloon cells were, or in this case, it picked out one part of the balloon cell, actually two balloon cells, and missed the rest of those cells. So, it is a challenge to do this and to do it accurately. And I'll come back to this in a minute when in another project where we looked at ballooning. So nuclear density was used to identify inflammation, and this is actually a lot of what computers are seeing when they do inflammation scores in liver biopsies. But you can see in this example that most of the nuclei here in this portal area are probably not inflammatory nuclei. They're bile ducts or vessels, other things, but the nuclear density is high, and that's what the heat map shows. But in fact, it does work not too bad, despite all of that, because most of the nuclear density will come from the lymphocytes. And so this is the lobular inflammation precision recall curve, and this is a kind of sensitivity specificity curve that you're used to seeing, the OROC, and except done with these other two measurements. And you can use it in the same way. You can look at the area under this. You can identify the best point, which, the optimal model gives you precision of 70% and a recall of 49%, which would be this point out here. And this is the ballooning, the same way with the ballooning algorithm. And it's actually the ballooning did better here. And this was interesting to me because if you look at reproducibility numbers of pathologists, ballooning is actually not too bad. It's lobular inflammation that's the real hard one that we disagree on more, and the kappa values are lower. So just as with humans, the computer has a harder time with lobular inflammation than it does with ballooning. One of the other things that came out of this study was we had one case that had a ballooning score that was off the scale. You can see it goes right off the top of this graph. But we had both Bill and I had scored it 0. So it should have been down here, and it was not. So, what it turned out to be was glycogenosis. So glycogenosis is a clearing of the cytoplasm because of glycogen. It has nothing to do with ballooning. The NASH network has studied this, and it really it's a fooler. It's a pitfall, and this is something that image analysis can fall into. And you can see this particular unfortunate. This is a published paper, and this is the picture they picked to show their ballooning. And the light blue is where the computer predicted the ballooning. This is not ballooning. These are normal sized hepatocytes. They're just pale. And this is glycogenosis. And I'm sorry that they picked this because their numbers really didn't look too bad. So I'm sure that most of their assignments looked like ours. They did a pretty good job, but they picked the wrong picture to put in their manuscript, which is too bad, but it makes a nice demonstration for me. Okay, so we're going to go on from these individual techniques to sort of all-in-one approaches. And this is where you have one, you give the computer a slide or maybe an H&E and a trichrome or an H&E and a serious red, and it does everything. It finds the steatosis, it does the fibrosis, the ballooning, and the lobular and portal inflammation. And this is sort of the holy grail of MASH image analysis, because, you know, if you can do this, then you can do the scoring for the pathologist, and it relieves us of a lot of many hours of work that's maybe not necessary. These were the first 5 publications. You can see the earliest one is 2019. So now we're actually not, this is not too long ago. And they're from all different groups. There was only one group, the Forlano group, that was just multi-center academic, and it was all European centers. The others were all companies. So Behringer Ingelheim was behind that one. HistoIndex, this was actually an academic study, but they used HistoIndex technology. This was a Rutgers study. I guess this was also academic. This was just Rutgers, and then this was PathAI. So the companies were already getting interested in this because they saw that there might be financial advantage to helping pharmaceutical companies with these determinations. So this is this very first paper, and this is as close as I've seen to a completely unsupervised model. So then this was mice. This is the only mouse study I'm going to show, although a lot of the AI stuff has been done with animals. And so what they did was they had the pathologist scores on one end, that was the outcome, and they fed it the whole slide image of the mouse liver, and a computational neural network sat in the middle. And I will readily admit that I do not understand the mathematics involved here. That's not where I trained. I was a math major in college, but you know, those days are long behind me. And so you feed this image into the neural network, and you say, match these scores on the other end, and you give it enough cases to train on, and it will figure this out. So, and it does, and this is what the output looks like. So you get heat maps out the other end. And so you can see here ballooning, and it makes this red blob over the balloon cell. It picks out this inflammation here. Interesting, when you get to steatosis, it also, of course, makes a heat map. And now you're seeing it cover areas that are clearly not steatotic. And the same way with fibrosis. So there are better ways to get at steatosis and fibrosis. But, you know, for a neural network, it did work, and, you know, it does pull it out, and it actually does pretty well. So the steatosis and fibrosis had the best correlation with the pathologist scores, and ballooning and inflammation were kind of a second. You know, they were lower kappas with the pathologist, and you can see inflammation was worse than the ballooning, even in the training set. So this kind of maps to what we all experience, and but it was a really good first attempt at this. So then they went on, this is the same group, they went on to do the same thing in humans, again, mapping to the AI or the pathologist scores as outcome, but then giving continuous measurements. And so here you can see the distribution of the scores. So this is, let's go to something easy like steatosis. So this is how the pathologist scored it, the 0, 1, 2, and this is the continuous AI steatosis score. And you can see that for steatosis, it differentiates pretty well. So the 1s come in between the 2s for the most part, and the 0s at the bottom. Fibrosis, not so good. So the lower stages of fibrosis are considerably overlapped. And it's not until you get up to stage 3 or stage 4 that things start to separate out. And the same way with inflammation. So you can see that, you know, between 0 and 3, you can tell the difference, but in the middle, things are pretty much the same. And there's a lot of overlap here between ballooning 2 and ballooning 1, although there is better discrimination here than there is here. But you know, what you'd want to do to improve this model is you'd want to understand why this model scored these cases, zero cases so high, up in the 2 range, and you know why this 2 came out so low. So you want to look at these extremes and then retrain your model based on, you know, fixing these problems, recognizing and fixing them. So this is their fibrosis, just another graph to look at the fibrosis with respect to the collagen area. And this does a better job at discriminating than collagen area, which is pretty characteristic. Collagen proportionate area does terrible at lower degrees of fibrosis. This is the histoindex based model. So this is a second harmonic generation, 2-photon excitation map of the scan of the liver biopsy. And so there's 2 signals here. There's the 2 second harmonic generation signal that gives you the collagen, and then the 2-photon excitation signal gives you kind of a map of the background liver. And this was a training exercise. So again, pathologists marked regions of interest, or you know, they marked out fibrosis and ballooning and inflammation and steatosis, and then the computer developed a computational model. This was not a neural network, but developed a computational model using individual parameters that it could measure off this biopsy. So you can see the number of parameters that were involved, and then they narrowed that down to a smaller number to give the final scores, which they're all abbreviated with Q's in front of them. And so this is their method. They start with the second harmonic generation signal, or the 2-photon excitation fluorescence signal, and they break this down looking at the fibrosis and then looking at the other structures. They can pick out nuclei, and again, they're using nuclear density to pick out inflammation. Steatosis is pretty easily found actually in the combined map of fibrosis and the 2-photon fluorescence. And they could pick out all of these structures. And, you know, again, they do reasonably well. So steatosis, very good. Fibrosis, good, mainly, again, in the high fibrosis stages. Not so good down here. Lobular inflammation shows reasonably good separation between 1 and 2. They didn't have many cases at the end, so it's really not fair to look at those. And then ballooning, you know, at least they're showing progression between these 3, and there's some separation between 1 and 2. So we're not too bad. So one thing to recognize in this model is that their Q inflammation score also includes things that they recognize as portal inflammation. So this is a portal tract running through the biopsy here, and they're picking out inflammation in that area. And so, you know, that is contributing to their total score. But of course, the pathologist would distinguish between the portal areas and the parenchyma. This analysis they showed in their presentation. So this is really not right. You shouldn't be using this kind of threshold analysis. This is typical for a non-invasive test, but you don't use this for image analysis. You don't want to say I'm above or below a threshold. You want to know I am at this threshold. So the last all-in-one that I'm going to show you is PathAI's approach, which was based on a convolutional neural network, but it was based on training. So it wasn't just based on the scores at the end. They had pathologists annotate images, and then they built their convolutional neural network on that. And their performance is also pretty good, although it's hard to see that in these graphs. So again, steatosis is good. Fibrosis is actually not too bad. I mean, it's a much better scaling of the fibrosis than what we had with the Q fibrosis, at least in their first paper. it's really hard to say what's going on with the ballooning and the inflammation, because you look at the numbers here at the bottom, they're huge. And so they have really tight bars here, and this thing is going to keep coming up. Sorry. It's really hard to tell what's going on down here. And then you wonder about this stuff. So again, as I pointed out before, you want to pay attention to these outliers. You want to know why this is happening. Why are we getting high scores of ballooning here on something that should be, would be assigned a 2, but the pathologist didn't think there was anything there. And you can do this even with steatosis. So what is it picking up here? What is it picking up here in the fibrosis? Why is this no fibrosis here scoring up in the cirrhotic range? And so it's important to understand why this is happening if you're going to make any improvements in these models. So just some of the things you can do beyond that. So this is a study, again, using the second harmonic generation. This was a negative trial of tropifexor. And what they were looking for is fibrosis improvement within a stage, right? So can we see fibrosis regression? And so this is an example of a case where before treatment, you had these sort of networks of collagen in between structures. And then afterwards, they're thin, they're broken, and the computer can recognize this. So that's what they did. They looked at areas, regions of the biopsy. So portal tract collagen, periportal, that sort of mid-zonal area, the perivenular, but sinusoidal collagen, and the central vein area. And there aren't, the case numbers are small, so they're not getting really good statistical power here. But what you can see is that there does seem to be, and this is significant here in the middle, there is a trend down with tropifexor in this transitional zone here and in the pericentral but perisinusoidal collagen. And so pathologists see this. We see this in the clinical trials that we participate in. These networks of collagen disappear. And so the machine is now able to reproduce that and demonstrate it. And so then they were also looking at using Q fibrosis as a continuous value to assess change. And because the pathologist was just using stage change, they were limited to these boxes of stages, but the computer could look at these less than whole stage changes and pull out more potential responders. Steatosis, the same story. So this is the pre-treatment. In the different groups, the histogram of fat vacuole size is pretty much the same, but you can see that in the 2 treatment groups, the size of the fat vacuoles goes down. So this was another study I was involved in. And this asked the question, can we create a model with an adjustable threshold for recognizing ballooning? And the problem is here, if the pathologist threshold is too high, then everybody, it's really hard for them to say that anything is ballooning, and patients get excluded from trials because the pathologist says there's no ballooning. If the threshold is too low, well, everybody gets into the trial, but no one responds because nobody goes to that magic balloon 0 score. So having a threshold that where you know where it is in the center of the range is probably the best. And so the idea was to collect annotations from multiple pathologists with different thresholds. So we had some people at this end, some people at this end, and some people in the middle. And can we define a median threshold that balances the needs of clinical trials? And it was designed to collect diversity. And so expecting it to be used as an inter-observer agreement study is wrong. And unfortunately, between the reviewers and the people who read the paper afterwards, this is how it's come out. And it looks terrible for the pathologists. And this has been an irritation to me for the last couple of years since this paper came out. This paper was not designed to answer that study or to answer that question. But it was designed to encourage this diversity. And diversity is good, recognizing that there's range of opinions and then finding, the best workable situation out of that diversity is always better. And so you can see when you look at the diameter of the balloon cells that we circled, we had a couple of pathologists who had this is down in the normal range of a hepatocyte, but most of us would want to see balloon cells that are a little bit bigger. We had one person who would circle groups of balloon cells, and that's why they ended up with, high scores way above everyone else. And so this is not quite right either. But that's, the machine looks at that as well. So if you look at the cells where there were 5 of us who agreed on the cell, then you got into this mid-range. And so this turns out to be a really good threshold for clinical trials. So here is a biopsy. There's a lot going on here. There's a lot of ballooning. And there was a certain amount of, circling fatigue that happened. Having done this now myself, I can tell you that this is not the most fun exercise, but you can see it's non-random. The balloon cells are happening in zone 3 where they're supposed to. They're not completely distributed randomly. And that's where you see, if we drew this as a heat map, this is where you would see the hot spots in these areas. So the threshold we ended up picking was the 5 pathologist threshold. And we've done a subsequent study that I think is going through the publication process now. Okay, so we started kind of late, so I'm going to keep going for about 10 minutes, and then I'm happy to stay as long as necessary. So this is, I think, the last study I was going to show you, which is that we can improve agreement by using these tools as assist tools. And this was a kind of a quick study that biopsies were staged by 3 pathologists. And in one, they reviewed them with and without the AI. And with the AI, they had the second harmonic generation image, the acute fibrosis stage, and the acute fibrosis value, the continuous value. And you could show that the scores went up from unassisted to assisted, both for inter and intra observer. And so this study, we repeated this study with a much more complex design with 2 rounds of randomization, 120 cases. Every case was reviewed 4 times, twice with AI and twice without. And they had this nice little image display so they could see everything all at once. And we showed the same thing. So we confirmed the study. The stage goes up, or I'm sorry, the kappa values go up if you use the AI tools as opposed to not using the AI tools. And the improvement is best in the low stages. So in this area where there can be lots of confusion and where there's an important breakpoint between F2 and lesser stages, we do really well. Not so good for the advanced stages, but it turned out the pathologists weren't using the AI tools so much, because when it's cirrhotic, and you can usually recognize that without AI. But picking out the at-risk patients, that worked better in both the first randomization and the second one. So just a couple things on tumor pathology. So this was an example of deep learning where you identify, you have a whole bunch of tumors, normal cirrhotic, adenomas, FNHs, dysplastic nodules, and well-differentiated hepatocellular carcinoma. And so you fed annotations of all of these different kinds of things into your deep learning model, and it then classifies these areas, and you can go back then and compare the answers that it gives with the pathologists. And this is just a really slick study. So you could see these are the color-coded prediction maps to differentiate nodules. So adenomas are in green, focal nodular hyperplasias are in the sort of yellow-green color. Dysplastic nodules High-grade dysplastic nodules and well-differentiated carcinomas are these different shades of from orange to sort of light red to sort of dark red. And you can see that in the well-differentiated carcinoma that it's assigning the edges actually to high-grade dysplastic nodule. And that's not too unreasonable, especially with a well-differentiated HCC, that you're going to have some areas that are going to look more just dysplastic and not so much cancerous. But the ability of the AI to differentiate between all of these different objects is really quite amazing. And then this study, which I'm just going to show you this one graph and this one study. This is a study that's happening at the NCI in our technology AI group, working with actually our group in some areas, Neuropath. But what they did, these are images from the TCGA cancer cohorts, where we've done genomics and transcriptomics, and you can take the H&E image, and they use the gene expression as the output, and they could show that they could recognize differences in here the epithelial mesenchymal transition signature or the proliferation signature mapped by different cancer type. So this is just pulling it off the H&E, which is just flabbergasting. But it just shows you how much information is in these images that we could potentially get out. And I think you could probably do this with fatty liver disease as well. I think you could have the computer, if you mapped it to the transcriptomic profile, I bet you could pull out the important pathways. So now for something completely different. This is sort of the downside of all of this. One of the responsibilities of the pathologist is to make sure the pre-analytic variables are taken care of. And quite honestly, there are some biopsies that neither digital nor optical microscopy will work. And this is a biopsy I had in the clinical trial I did recently. And you can see that whoever cut this biopsy was using a dull blade. It's completely shattered. There are bits of biopsies scattered all over here. It looks bad from low power. It looks even worse from high power. I just couldn't do anything with this, and I had to call it inadequate. And there's nothing that I would expect a machine to be able to do with this either. So these are some of the other artifacts that you can see. This is the same knife artifact here, just not as bad. It's called chatter. This is a tearing artifact that we see a lot with fatty liver disease, where the biopsy sort of shreds through the middle. Here, this is autolysis. So this biopsy didn't get into formalin right away. These are folds in the biopsy caused by a water bath that wasn't at the right temperature. And then one of the things you can have in a very fatty liver is the vacuoles can start to merge. So you can, the cell membranes break here, and the lipid kind of flows together. And it would be very difficult for a computer to recognize this as a fat vacuole if it was looking for characteristics of roundness. And this is an artifact caused by the whole slide imager. So the strip on the bottom is in focus. This next strip up is not. And this is really hard for the machine to detect, to tell you that it needs to be rescanned. You can really only pick it up once you look at the biopsy at high magnification. And I have no idea how this affects the AI analyses. Arun Sanyal and I wrote a review, or actually it was a perspective, not a review, for Nature Reviews, that looked at these questions. And so this graph is a really nice demonstration of all of the things that could potentially affect the outcome, the data interpretation. Some of these AI can work around, some of them it cannot. And we as pathologists need to do a better job in the histology laboratory, making sure the slides are good quality. But the choice of the scanner, one of the questions I have about all of these commercial techniques is how scanner dependent they are. Are they going to be out of date in 5 years when the technology changes? So then, and the analytical piece is mostly what I've shown you, the algorithm and training models, sensitivity and specificity, all of this. Hopefully this will be the last one. And then sample to sample variability is something we always worry about. So just some final thoughts. Artificial intelligence and machine learning, they're tools. And it's important to remember with any of these models that we use, whether they're pathology or radiology or medicine or large language models, they're tools. They augment the information that we as pathologists can use to provide to our clients, the hepatologists, oncologists. And H&E sections contain far more information than I, as a human pathologist, can report out. And so we can extract that information using AI. And then digital pathology analytics, they do promise a lot, but there's a lot of validation work to do. And a lot of this is not published. So I encourage companies and individuals to publish their validations and all of these pre-analytic variables that, so that we know, do they affect it or not? And this is my dream, right? So I'm sitting here in the middle. I've got slides to examine. I've looked at the gross and selected my sections if necessary. And then I get to decide what models to apply. I can use my AI tools. I can predict things that are molecular. I can have it scan the slides for important features and quantify. And then you can combine this then with molecular pathology and report out a really complete analysis of whatever it is. You could look at the AI predictions, and then 3 weeks later, when the molecular comes back, you can confirm these results. And the more confident that we are that these results are good, then we can proceed maybe with therapy right away. So that brings me to the end. And thank you very much for listening.
David, thank you. This was a wonderful talk. I think it's a unique talk. Our audience will agree. And I thoroughly enjoyed every slides that you presented today. A lot of information, very innovative, and the future looks very bright in this area.
I hope so.
Yes. And I would now let the topic open for any discussion, for any questions. I see Dr. Pallavi Bhuya already ready to ask questions, looks like. Dr. Bhuya, please go ahead.
Oh, it's an honor. I'm from India. I have the privilege of seeing liver biopsies. I worked with Professor S.P. Singh, sir. And I just wanted, because I read about Kleiner, we were reporting in the name of you, sir. So I wanted to thank you very much. It's an honor, really. I'm very happy, thrilled to see you.
I'm so glad we had a pathologist on. So yeah, I have been blessed, and I recognize that, it's an important thing to be able to do these things, and I'm blessed to be part of it and to help other people understand it. Because we have another question.
Thank you. Yeah, Dr. Pragadala, please introduce yourself as well for the audience. We all know you.
Hi, Dr. Kleiner. This is Mangesh Pragadala. I'm one of the transplant hepatologists in Methodist Dallas. And I've been part of the NAS and the NAS CRN for quite some time in the past. I always wanted to meet you and ask you this question as to what made you bring ballooning into the picture of, this looking at the histology and the clinical implications in NASH and treatment other than just clinical trials. Because I know you focused a lot on ballooning.
Yeah.
And it's very, very controversial because I think 50% of the hepatologists even don't understand what this ballooning is. So I wanted to see what your thought process is. And, why have we moved away from fibrosis, steatosis, inflammation? Because there's so much of emphasis on ballooning now.
Right. So, well, there are a couple of reasons. I mean, one is the sort of historical reason that, you know, a lot of what we do with steatohepatitis comes out of the alcohol literature. And so the early descriptions of alcoholic hepatitis really focused on the cell injury that, you know, with the Mallory body formation. And, you know, so we all felt it was an important part of what was going on. And when you look at a liver biopsy carefully, and especially on a trichrome, a good trichrome, you can see that the fibrosis actually begins around the balloon cells. That's where it kind of starts. And so it was this sort of combination, sort of visual combination of ballooning, usually with some inflammation, but the inflammation in steatohepatitis is less than it is in chronic viral and less than it is in other diseases. And then fibrosis. And those three things kind of coalesced in the middle of the lobule, right, in zone 3. And so when we came up with the, you know, so the early papers that were looking at steatohepatitis divided the world into cases with ballooning and cases without ballooning, and showed that the ones that had that feature did less well, right? They progressed. Whereas the ones that didn't have ballooning, they mostly stayed the same over time. So that was the other thing, is that there were some prospective studies that predated the NASH CRN that also helped us say that this was an important feature. So.
And do you think it's time to revisit the NAS criteria for, like, you know, use machine tooling to look for other markers?
So that's a really excellent question. I mean, one way to do that is to look at, you know, distant outcomes, right? So you look at these hard outcomes, and, you know, within a certain time frame, and you say, okay, what features on the biopsy, you know, point towards that end? You know, I think one of the things that you would find is that fibrosis comes out. I mean, because it does. It comes out ahead of everything else. Stiffness, you know, which is a combination of fibrosis and other things, comes out ahead of everything else. So I think, you know, probably what it would do is it would find the fibrosis first, and then it might find these other things, but it would probably be inflammation, and ballooning would be a secondary thing. Because we know that in short-term paired biopsy studies that, you know, when you're looking at progression of fibrosis between 2 points in time, that the ballooning and the inflammation are more important than the steatosis. So you know, fibrosis is fine. If what you want to know is what's going to happen to the patient in 20 years, that's fine. You know, you can draw these life tables and that works. If you want to know what's going to happen to the patient in a year or in 2 years, then you have to look at the activity of the disease. And I didn't talk about disease activity versus disease stage, but they're two different things. Stage is where you are along the path to the end. Activity is how fast you're going. It's how quickly you're going there. And that's what the ballooning and the inflammation tell you.
Thank you. It was an excellent talk, and it was a pleasure to attend your discussion. Thank you.
Thank you, Dr. Padula, for that question. David, I have a question. In the clinical trials, we have endpoints of the treatment. That is NAS resolutions or no worsening of fibrosis, whatever we have defined. What is the endpoint for a patient when we start the treatment? Are we still going to continue to use those clinical trial endpoints, stop the treatment at some point, or no, if the patient meets that criteria?
So you're talking like real life here. How do you know when to stop treatment? That's a really excellent question. I'm not sure we know the answer to that yet. You know, I mean, one answer is that this is a lifelong disease, right? It's like diabetes. It's like hypertension. You don't take somebody off their hypertension meds unless something really drastic happens in their life. So, you know, the answer may be that we have to keep patients on these long term, which, you know, is maybe not such a good thing. We don't know yet how that would pan out. The other possibility is, well, maybe you reset things, right? So maybe what you do is you drive the fibrosis from bridging down to minimal, and you say, okay, we've given you another 20 years, we take you off the drug, and you go on. But what we don't know is how quickly the disease rebounds after we've stopped therapy. And we really need to understand that, I think. There isn't much data with biopsies, but we did a small study at the NIH, and patients bounce back really fast within a year or two. And they're right back to where they were in terms of their disease. And so that, maybe that's, that was a small study, and, it definitely needs to be redone with the drugs that we have now that we know work. But there may be some medications that actually help reset better than others. And so that would be important to know.
So the resolution of disease activity, let's say the NAS scores are zeros, would that not meet the criteria to stop the treatment?
Sure, you could stop then. The question is, have you really changed the patient's underlying problem, right? So we know with bariatric surgery, if the patient keeps the weight off, the disease goes away, and it really does go away. But you've actually changed the situation. They don't have their diabetes anymore. They don't have the lipid problems that they had before. So if we can get there with other kinds of interventions, then great. You don't need to stay on the medication. But what we don't know is, even if you drive them to normality, which nobody's done yet, right? Even if you do that, then how quickly does the disease recur?
Thank you. Dr. Prasoon Jalal, please.
Hi, thank you. It's a fascinating talk. I'm a transplant hepatologist from Houston, Baylor. There is so much inter-observer variability amongst the expert pathologists, confounding the whole result. So I was wondering, the AI at the moment is as good as you train it. It's unsupervised training is better, because expert pathologists are having so much variation. Even the concordance rate is probably less than 0.5. So maybe we need to change our strategy, rather than making AI in a biased way to pick up things. So that's one thing. The other thing I was wondering, that I know your vision you mentioned, which is fascinating. Again, why not? Nowadays, we're going to a non-invasive way. Why not AI interfacing between radiology and pathology? So we don't have to do invasive biopsies anymore. You can look at the picture in a non-invasive way and give your opinion. What do you think about these two?
So the first question, I agree that, your ground truth here is a little bit shaky, right? So that was what we were trying to get at with that ballooning study. So in that case, the diversity of this disagreement, and it wasn't true disagreement, right? It was thresholds, different people's thresholds. Low threshold people picked a lot more cells out than the high threshold people, but they tended to overlap. The low threshold people overlapped with the high threshold people on the cells that they picked out. So you build up this heat map, and that gives you more information than any one pathologist assigning a particular cell, right? So that's one way to get around this problem. I did show you one, sort of general unsupervised analysis where they just targeted the scores. But you could, target an outcome, and it would probably pick out some things. But if what you wanted to do is quantify these different things, then you have to give it some target to look at. And it did pretty well, at least by the pictures that they showed in the paper. It could pick out balloon cells, and it could pick out inflammation. I think there are better methods to get at fibrosis and steatosis, because those are objects we can define without necessarily, highlighting them for the computer. So I think that there is value in this, and I think there's more information there than once we can use these continuous values, then we can stop using the semi-quantitative ones. And even in the continuous values, there's going to be a lot more information. Continuous values of fibrosis, continuous values of cell injury and other things. So there is value to that. And then the second question is, could we do this with radiology? And believe me, there's a lot more of this AI stuff happening in radiology than there is in pathology. It's like, an order of magnitude or more studies, and they're doing them in the fatty liver space too. But there are limitations to that technology as well. So resolution is one issue. And so we have some studies that are going to the RSNA this year from the NASH CRN that look at trying to using AI and stiffness measurements, PDFF, to try and pick out texture differences and things like that will get more at activity of disease and not so much the things that we usually measure from. And there is something there, and maybe we can refine it to do better. But right now, those tools are pretty limited. But it's not to say that they won't get better and that people are not trying, because they are. Radiologists want to be in this space as much as we do. So I think you just have to wait another 5 years or so.
No, thank you. I appreciate it. Thank you.
Yep.
Thank you, Professor. Dr. Benedict Meliaco.
Dr. Kleiner, that was quite an amazing talk, and we are not used to this kind of talk, so this is very, I think it helps us to think a little differently. I had a comment. I mean, one thing I think we clinicians are afraid of AI, and the radiologists are also, I think, afraid of AI, but I think pathologists for at least the next 20 years don't have to be afraid of AI as much as we have to, because I think people are going to compare clinicians to a computer or AI.
Yeah.
And radiologists are probably going to be compared to AI a lot before pathologists are compared to AI because of the complexity in terms of pathology.
Yeah.
That's my comment. And the other question is, from a pathology standpoint, who do you think will benefit from liver biopsy? Because we are moving away from biopsies. We used to do tons of biopsies 30 years ago, and now we hardly do any. We try to, not do biopsies as much as possible, except in studies. And so from your standpoint, and then the other question is, if AI and other things, the pathologists can look at, say, fatty liver in a patient and predict based on cells or whatever it is, on the pathology, whether this is going to progress. I mean, because we know that some fatty liver doesn't progress and some fatty liver progresses quickly. I mean, is there some way of predicting, early, just from an early liver biopsy, say in a diabetic, and we can then classify people into high risk and low risk of progression?
Lots of questions. So maybe I'll start at the end. I think the answer to that is yes. I mean, a lot of it requires data, right? People to do the studies. We are doing a couple of large-scale studies now. The NASH CRN is using our biopsies with 2 companies, and progression between biopsies is definitely something we're going to be looking at. And so hopefully that information will come out, that there will be subtle patterns in the biopsy that will tell us this person is going to progress, this person is not. So that's one of the things that might come out of these studies. The role of the biopsy is changing. I mean, there's no question about that. You're not going to be using it for staging, grading. I mean, we already dropped it for, most nobody with hep C gets a biopsy anymore, for example. And hepatitis B is very rare. So we don't use it for chronic viral hepatitis, except when there's something that doesn't quite fit, when you think there might be something else going on. And then you need a biopsy to maybe figure that out. I think there are always going to be clinically challenging cases that fall outside the common diseases for which a biopsy would be valuable. Non-cirrhotic portal hypertension is one of them right now to understand, what exactly is going on in the liver. You may find things that you don't expect. So at least right now, that's a reason to biopsy somebody. Whenever you have more than one thing going on, or you think that there's more than one thing going on, or you're in a differential point where it's hard to know based on the clinical criteria that you have, you aren't sure what's going on, right? Or you've got a differential that you can't decide, that might be helped by a biopsy. So I think those are the sorts of areas where biopsy is still valuable. It's still valuable in rare diseases to understand what's going on and to decide. One thing about non-invasive tools that you have to remember is that they don't. The response of a non-invasive test may vary between diseases, right? You can't assume that the same stiffness value is going to mean the same thing in somebody with chronic viral hepatitis as steatohepatitis, as PVC, as hepatitis delta. They don't.
Right.
Yes, in general, they move together, but they don't, the same number will look at a different pattern of fibrosis and other things in the liver.
That brings me to one question. I mean, people use, say, fibrosis markers. The thing is, sometimes maybe we have to correlate imaging with pathology with fibrosis markers, because fibrosis markers are not static. And based on the pathology, the fibrosis markers may vary in different patients. And so maybe there should be some correlation with pathology, imaging, and non-invasive like blood markers.
There are those studies, and I mean, yes, and it depends on what you need to do to take care of your patient, right? What kind of information you need, and maybe there's many situations where you decide, well, I can manage this patient okay, but if something unusual comes up where my non-invasive tests are giving me different results, and I just don't know what to tell my patient, then that's maybe a situation for a biopsy. So it'll be much more specialized. I mean, it becomes a training problem for me, right? I have to train the next generation, and I'm not going to have as many things to show them. But, that's my problem, really. And, you have to use this as a tool, right? And I'm your expert consultant. I understand, the pathology of liver disease. I do understand enough clinical hepatology to kind of, understand the history and how it impacts the biopsy. So I can look at the biopsy and I can tell you things like, I think this patient may progress. I think this is concerning here. I don't like the way that this looks. It's fuzzy, but I'm a consultant in this role, right? And I'm being your clinical colleague to help you manage your patient. And I'm doing so with my expertise, my visual recognition skills, my brain. And that's what happens with drug-induced liver injury a lot, right? So I look at a drug biopsy and I'm looking at it both, what's on the glass, what's in the patient's history, what medications have they taken, and all of that information gets filtered together. And then I can say, I think this is the drug, or no, this is not a drug. This is something else. None of the drugs do this. And I've said both of those things over the years. So I think, it's going to be a challenge for all of us to learn in this new environment. I think it's really important to remember that AI is a tool. It is something for us to use. We control it. We should decide, we as physicians should decide when it's applied and understand, the information that it gives us, when it's hallucinating, when it's, be critical, and we have to train our next generation of physicians to be critical, to look at this as another information source, and to think of it carefully and critically, to understand the biases that go into these models. What works in my hospital might not work in your hospital because you have a different patient population. There might be all kinds of sample acquisition bias that's built into these models. So we shouldn't just use them blindly. We really do need to understand the data that went into them, the potential flaws of the algorithms, how it, whether it managed things or not. It's not, and I understand the temptation of, well, the computer gave this answer, doc, you were wrong. That's not the way it should be. It should be, the computer provided an answer, but I think that we need to, further evaluate this.
I think we are in that bridge generation, and we think
Lucky
that
us.
way. But it's almost like what I'm afraid is like GPS. Nobody knows the way to get there. They just put the GPS on, and that's what AI might make people not think too much.
How many of you know how to use the slide rule? I learned how to use the slide rule in high school. We didn't have calculators, right? No, nobody knows, right? But the devices that we use, the calculators that we use, have been so tediously validated, right? Because it was vitally important that the computers get those calculations correct. So we can depend on them, 100% of the time. But you can still play games with the numbers. You can still do things like create round off errors that accumulate. And so, with any of these tools, we need to be healthy skeptics. And I understand your fear, because we're not immune to it either. But quite honestly, they said that with molecular pathology too. They said, we won't need pathologists anymore for tumors. We'll do the gene signature. We'll find all the mutations. We don't need you. Nah, that did not happen. It became our tool. Molecular pathology is its own discipline now. And, the same way with immuno, the same way with electron microscopy, they said, we don't need microscopy anymore. It's nonsense. So we need to get through this period of time, that we're living in all right now, right? We live in interesting times. That's unfortunate. But we need to get through this and learn to use these tools better.
Thank you.
Well, with that note, I think we will stop here. We are about 8 minutes past our stipulated 9:30 time.
Yeah.
But David, for staying longer, and thank you the entire audience who stick to the entire time here. I think it's straight from the mouth of the horse. We hear the best talk from the best from the world.
So thank you so much. I really appreciate this opportunity.
Thank you. And the talk will be available in the website. So if anybody missed it, please visit the website and listen to the talk, and also spread the word, because this is a very important talk. I think and everybody will learn a lot by listening and going back again and again for the same talk. I'm planning to re-review the entire talk again. Thank you so much.
Okay. Well,
all right, we'll stop here. Thank you.
Thank you.
Have a good day, everyone.